Well, thank you very much, everybody, for being here, and thank you for the kind invitation. We're going to be talking about what is available right here, right now, in terms of atypical Parkinsonism, MSA, PSP, and corticobasal syndrome. So a few years ago in 2021, a lot of us gathered together and under the leadership of Brent Blewett and of course Larry Golby, and put together this great paper that I would advise all of you actually to take a closer look at. It has a lot of information. Basically, a lot of stuff that you're going to see in my talk are based on this paper, but I try to expand it a little bit more and also talk more about multiple system atrophy treatment. So this paper focuses mostly on PSP and corticobasal syndrome, but it's a great paper, still very up to date. So it's going to be a straight to the point talk today, actually. What can we do for those syndromes? We're going to start with progressive supranuclear palsy and the motor issues that people deal with. Of course, the mainstay of treatment is basically levodopa. Very old drug, but very efficient. Starting low, goes slow, and you titrate it up to a dose of 1,000, 1,200 milligrams. This is justified in patients who can tolerate this. Not everybody can tolerate this. Some people get, side effects. They can get, drowsy. They can have hallucinations. So start low, go slow, but, you can't, quit until you reach a sufficiently high dose or the patient develops side effects. So for gait and balance issues, oftentimes we use amantadine. This is a very old medication that, used to be used decades ago for the flu, but we use it in Parkinson's disease. We use it also in atypical Parkinsonism quite a bit. Coenzyme CoQ10 is also something that we can try. There were like a few double-blind trials that justified its use. It's benign. It might be a little bit expensive. It's worth a try. PTOT for every patient is definitely something that we need to consider and deploy for dystonia in PSP, but also in all those atypical Parkinsonisms. We use a variety of medications, potentially low-dose muscle relaxants like baclofen, clonazepam, but also botulinum toxin injections. Now, keep in mind, botulinum toxin is a great medication. It doesn't have systemic side effects, but at least of my experience, sometimes patients need high doses, or they're very resistant to Botox injections, but this is a very good choice for those folks who cannot easily tolerate muscle relaxants, and that is very usually the case in patients with atypical Parkinsonism. Spasticity, the same rules apply, the same principles. You can try oral medications for spasticity. If patients don't tolerate them, you can jump off directly to botulinum toxin injections, and that might be even more the case in corticobasal syndrome, where patients have, very asymmetric findings. They have, bad spasticity / dystonia. So keep that in mind. For dysphagia and dysarthria, I think this has already been, very well expanded upon already. Speech therapy referral is of utmost importance. We will discuss it in the MSA section, but basically, Thea and Karen have already discussed it in quite detail. Now, some non-motor issues patients may have: sleep disorders. We can try melatonin, Ambien, the ingredient is zolpidem, clonazepam, a variety of medications. For restless leg syndrome, we can try gabapentin or the extended release of gabapentin. There is a medication called Horizant, Lyrica, pregabalin, iron supplementation, dopamine agonists in very, very low doses can be considered. Again, typically dopamine agonists do not agree very well with those patients, so just be careful when using them. Use them in low doses and titrate carefully. For REM, sleep behavior disorder, we're going to talk about it a little bit more in the multiple system atrophy section. For excessive daytime sleepiness, sometimes people are sleepy, drowsy. Stimulants can be used. Low-dose amphetamines can be used. Now, do patients tolerate them well? Probably not, but this is something to consider. Apathy is a feature that patients, lose the internal drive to do stuff. They lose the energy to, execute things. They don't have enough internal stimulation. So low-dose amphetamines can be tried. Sometimes you can try, SSRIs, but, typically they may not work very well. Apathy can be seen outside of the context of depression, but it can be seen also along with depression. Now, for drooling and sialorrhea, we're going to talk a little bit more about that in the multiple system atrophy section. Other non-motor issues, cognitive deficits, a trial of like an Alzheimer medication like Exelon can be justified. Typically, the patch is a little bit better tolerated than oral pills. But again, the response is very variable. That means not all patients respond to the same degree to those medications, so we really have to be, careful. Sometimes, we use those medications for freezing of gait in Parkinson's disease, in PSP, and the other atypical Parkinsonism. The improvement is like completely unpredictable. Sometimes you may see worsening, actually, so be very careful. A lot of times those patients are impulsive, so SSRIs, mood stabilizers can be used, and of course cognitive and behavioral therapy to just take it easy. We know the thing that people tend to get like big sips and bites in PSP. This is very common, so pay attention to that problem too. Depression, again, antidepressants, behavioral therapy. Now there is a thing called pseudobulbar affect, where patients tend to cry or laugh out of the social and emotional context. That means inappropriate laughter. So this can be seen in a variety of neurological conditions like ALS or stroke, but it can be seen also in atypical Parkinsonism, multiple system atrophies. Patients sometimes have it, but also PSP patients can have it. There is a medication called Nuidexa. We're going to talk a little bit about that a little bit later. Now, as far as the eye/visual problems are concerned, those have already been discussed. I'm not going to talk too much for the sake of timeliness. Oftentimes, PSP patients, they develop this apraxia of eyelid opening, so difficulty keeping the eyes open, or they may develop blepharospasm, so botulinum toxin injections can be quite effective. They may develop, dry eyes, so artificial tears, and other things can be deployed, like eyelid crutches for difficulty to keep the eyes open. Now, changing gears here, going to the corticobasal syndrome. So the Parkinsonism here is less responsive to levodopa compared to the other two atypical Parkinsonian syndromes. So typically patients tend not to respond, but again, a trial of levodopa is here justified. Amantadine can also be tried here, as with all the other atypical Parkinsonism. Again, the results are not very good here, as opposed to the other two Parkinsonian syndromes, and dopamine agonists and anticholinergics are not indicated here because they may worsen cognition. You may have hallucinations and other problems. Typically, we see myoclonus, so those sudden jerks of the upper extremities in corticobasal syndrome. Classically, we use clonazepam, which is a sedative. It's a benzodiazepine, but we can also use Keppra, a medication used for seizures, but we use it quite a bit for myoclonus too. For dystonia, as I already mentioned, we can use botulinum toxin injections. Sometimes I've had to use extremely high doses to get it under control, so people can be very resistant to botulinum toxin injections from the get-go, as opposed to patients who have, spasticity due to a stroke or multiple sclerosis. We already talked about the other problems like aphasia and apraxia. So aphasia, speech pathology referral, oftentimes there's apraxia of speech. People tend to forget how to articulate properly. Therefore, an early speech therapy referral is indicated for apraxia. That means difficulty to know how to properly do things, execute orders, and occupational therapy referral may be indicated. Again, here for cognitive issues, it may be worth trying an acetylcholinesterase inhibitor. Those are typical the Alzheimer's drugs that we use. But again, the result is completely unpredictable. It is interesting that sometimes the underlying pathology in corticobasal syndrome could be beta amyloid, so Alzheimer's pathology, and sometimes people think, okay, this may justify a trial of an Alzheimer's drug. Behavioral issues may ensue, and therefore behavioral therapy, SSRIs, can be tried. Moving on to the multiple system atrophy, motor symptoms, same rules apply. I don't want to be, making you even more drowsy, as some of you might be post post-lunch, but again, same stuff, start levodopa. Here, the problem in MSA is the orthostatic hypotension. At least 80% of patients with multiple system atrophy have orthostatic hypotension. That means low blood pressure. And this may get exacerbated by levodopa. So not everybody has it, but a lot of people, most people have it. So start low, go slow. Consider amantadine, avoid dopamine agonists. So same principles apply. For dystonia, we discussed that already. Same for myoclonus. Now, ataxia, that means lack of coordination, is a difficult feature to control with medications. Basically, we don't have good drugs for that. PTOT is indicated. Now, you may try empirically some relatively benign medications like memantine that we use for memory problems in Alzheimer's, or buspirone, which is an anti-anxiety drug. But typically ataxia does not respond well to medications. Other non-motor symptoms, like a very important non-motor symptom in multiple system atrophy, is the low blood pressure, orthostatic hypotension. So we have a variety of medications we can try. That's a good thing. Like fludrocortisone, that increases the volume of water in the bloodstream. It helps the body retain some salt. We have midodrine, which makes the blood vessel constrict. Pyridostigmine, which is essentially a medication that we use for myasthenia gravis. Sometimes it may cause some drooling, but we can use that as well. Another medication called droxidopa. So a lot of stuff we can use, sometimes in combination. Some combinations are not to be used together. Typically, we want to avoid midodrine and droxidopa. So we have a lot of treatment options, and most of the times you can get the orthostatic hypotension under control. Now, sometimes people tend to have this roller coaster phenomenon, so very high blood pressure when they're flat, supine, very low when they get up. So you sometimes, although it is counterintuitive, you have to use both medications that increase blood pressure and low-dose medications, especially at bedtime, that lower blood pressure. So that's a difficult scenario, but this may happen. Other non-pharmacological approaches that I think we should all keep in mind would be to increase the water and salt intake, high compression stockings, like thigh high compression stockings, not up to the knee, and abdominal binders. Sometimes people have postprandial hypotension. That means blood pressure goes down after a meal, so we can use medications like acarbose or caffeine just before meals. Other non-motor symptoms in multiple system atrophy is the urgency. There are a couple of treatment options here. Obviously, this is going to be the topic of the next talk, and I'm not going to, expand upon that. We tend to love the first one, the mirabegron, which is a beta-3 agonist, which is a medication that actually increases as a side effect blood pressure a little bit, which is something that we want in multiple system atrophy, and we want to avoid like older generation anticholinergic bladder medications that may worsen cognition. Botulinum toxin may be another option. For men, condom catheters, another neuromodulation approach called transtibial nerve stimulation. A lot of things here are going to be, again, the topic of the next discussion, so I wanted to say a few things about the erectile dysfunction, which is a feature that affects men. Here, medications like Viagra can be used. The problem is those patients, the MSA patients, are super prone to orthostatic hypotension. So this could be actually a ticking bomb. So keep that in mind. Be very careful when you deploy those treatment approaches. I tend to be very careful and tend to early refer my patients to urology for a thorough and comprehensive evaluation. So that's very, very important. For drooling, there is a couple of treatment options. There are medications which are called anticholinergics, like glycopyrrolate, which makes secretions go down. Atropine drops, so eye drops, atropine eye drops that you instill under the tongue, and they cause dryness of mouth, but also botulinum toxin injections in the submandibular and parotid glands. Those can be repeated every about 3 months. For the REM sleep behavior disorder, that means dream enactment, like yelling and thrashing around your sleep, melatonin is an easy option, very benign. It doesn't work very well, but it's really worth a try. Worst case scenario, it doesn't work. Clonazepam is a medication that works very nicely for the vast majority of patients. It may cause some sedation next day, so start low and titrate that up slowly. Patients with multiple system atrophy, a big issue here is sleep apnea or nocturnal stridor, and they may pose a risk for sudden death. So early detection of those through careful questioning, referral maybe to pulmonary medicine, consider like a sleep study is very, very important. And you know, working with a pulmonologist is of paramount importance here. Pseudobulbar affect, we mentioned that a few slides before. There is a medication called Nuidexa that can be used for pseudobulbar affect regardless of the etiology. Here, you know, we may have some issues with cardiac problems, so therefore clear the patient from a cardiology standpoint. Make sure you work with a cardiologist before you get it started to avoid getting into, you know, heart problems. Non-motor symptoms, Thea said actually, you know, dysarthria and dysphagia are also motor symptoms. You know, I kind of like agree, but I put it under non-motor symptoms. Here, speech therapy, this has been already, you know, discussed in much detail, and working closely with speech and language pathology will get patients in a better position, avoid or at least reduce choking risk. So, basically, we all know that what we have right now is not sufficient. It's not good enough. We know that very well, and pretty much this is stuff that people talk about. We use it in our clinics all the time, but okay, what else can we do right here, right now, although there are things going on in the pipeline? So those are kind of like, you know, off-label approaches that I wanted to briefly discuss. Those are neuromodulation approaches for, I mean, definitely they have been deployed for Parkinson's disease, but the question is, can we do something beyond Parkinson's disease? So there is something called deep brain stimulation, which is no standard of care for Parkinson's disease for a couple of decades now. There have been some studies deploying deep brain stimulation, essentially putting the electrode most of the times in a small spot in the brain called pedunculopontine nucleus, which is exactly at the center of the brain. Long story short, the results have been mixed. I mean, there hasn't been any clear evidence there is a big improvement after that, plus that approach may have some risk for the patient. Therefore, its role of DBS still remains unclear. There are some issues with safety and efficacy, clearly like non-FDA approved for this indication, so I don't think this is going to move forward much more. Now, a less invasive approach is something called spinal cord stimulation, essentially putting electrodes on the dorsal, the back portion of the spinal cord. This is something we use like quite frequently for treatment refractory pain. This is used all the time by spine surgeons and anesthesiologists. There have been limited studies looking at spinal cord stimulation for freezing of gait, both for Parkinson's disease, but also for atypical Parkinsonism, because oftentimes we have this nasty, unresponsive freezing of gait. So a few patients with PSP and multiple system atrophy have been implanted with spinal cord stimulation systems. The results are mixed, a little bit over the place. We don't have a very good guidance. Now, obviously, the benefit as to deep brain stimulation here is this is a less invasive approach, clearly completely off-label, but you know, spinal cord at this juncture still remains investigational, and we need more and better studies. So moving forward to other non-invasive neuromodulation approaches, there is something called repetitive transcranial magnetic stimulation, or RTMS. So basically, this method uses a coil to emit electromagnetic fields to the brain, essentially stimulates, or conversely, depending on the frequency, can suppress electromagnetic activity in the brain. This is clearly FDA approved for treatment refractory depression and OCD. However, RTMS, I mean, has been, you know, tried for a lot of neurological disorders, also neurorehabilitation. And there have been some studies looking at RTMS for atypical Parkinsonism with some, I would say, probably, you know, a little bit encouraging results. The good thing about this method is this is non-invasive. It doesn't have any huge risks. Typically, patients with epilepsy are avoided for this. But this is something we may want to look closer at because this is available at least in many psychiatry offices. Another non-invasive approach, which is, I would say, probably, you know, a cheaper version or a poor man's RTMS, is something called TDCS, transcranial direct current stimulation. Basically, it uses two patches that apply an electrical field that, you know, penetrates the brain. There is no FDA-approved indication for that. It has been used, you know, for a variety of conditions. You can even like buy devices, you know, on Amazon, which is something, you know, I don't clearly recommend. But this has also been tried in a variety of neurological conditions, including atypical Parkinsonism. Has this been well studied? No, but a few studies showed a little bit encouraging results. So I think this is something that from a clinical standpoint should be better looked at. And in summary, I mean, caring for our patients, we need like a good multidisciplinary team, a lot of specialists to achieve optimal outcomes. We know that current therapies do offer some relief, but we are desperate for better and more effective treatment options, and especially, disease-modifying therapies. And definitely CurePSP and all of us are here for you. And with that, I would like to thank you so much.
So we're going to take questions afterwards for the both of us. This guy's a tough act to follow, right? All right, wow. Welcome, everybody. I'm really happy to be here. This is one of the most exciting things that I get to do, because I get to talk about science, and in particularly neuroscience. My name is John Goodrow. I'm a physician scientist at Michigan State University in the Department of Neurology and Pharmacology and Toxicology. Been there since 2001. When I came at that time, my goal was to develop disease-modifying therapies that slow or halt the progression of neurologic movement disorders like PSP, CBD, and MSA. We're not quite yet there, but I think what I want to explain to you, that there's some hope for the future. And I'm guessing he's a little bit taller than me, sorry. This is a topic of interest, I think, for everybody in the room, I'm guessing, right? All right, good. So just by way of disclosures, I do get some research support from some pharmaceutical companies listed at the bottom of the slide. None of these are the trials that I'm going to be talking about today. So we need to do a little background work and talk about phases of therapy development just to make sure that we're on the same page. And I'm going to focus this talk mainly on small molecule drugs and biologics, that is antibodies, proteins, peptides, genes, and maybe a little bit of cell replacement therapies. I don't really have time to do non-medication treatment modalities. Fortunately, Dr. Sid had just covered some of the neuromodulation stuff, and we heard a talk earlier about some fantastic stuff that's going on for speech. And we'll hear a talk after this about bladder dysfunction, but nutrition and exercise are also very important treatment modalities. I just don't have time to go into those areas. So if you think about phases of clinical trial development, it's broken down into preclinical phase, and there's an enormous amount of work that goes on at this stage. That means identifying a target to go after, validating that that target is relevant to the disease that you want, screening for drugs or small molecules or biologics that interact with that target, and then showing that there's no abnormal safety signals that would preclude going forward, then showing that they're effective in preclinical animal models. And then and only then do you get to what's called phase one. That's the first trials where it's used in a human. Usually phase one is people that are normal, healthy volunteers, just to show how the drug distributes around the body and that it doesn't cause any unusual side effects in normal people. Going on to phase two, usually is when the drug is first used in the target population on a small number of patients to show that it's safe and effective to use in that target population, and to make sure that it perhaps engages the target that you're going after. And then when you get to phase three, that's the phase where you're proving whether the drug actually works or not. So I wanted to cover that because a lot of the trials I'm going to talk to are in that phase one and phase two area. We have very few therapies that are in phase three testing for any of these diseases. The other thing that I wanted to point out is the attrition that goes on. You start out with tens of thousands in the preclinical or basic area, and only a few of those make those into phase one, and very few of those end up becoming an approved drug. So you have to screen 20, 30, 40,000 molecules to get to one drug that makes it all the way through to an FDA-approved treatment. So that funnel is one that is one to consider. The other thing I wanted to point out, and I hope we have time to come back to this, is 98% of the drugs that were approved in the last 5 years by the FDA at some point used NIH funding to propel that therapy development program forward. So think about that. Everything that we had in the last 5 years largely depended on having some input from NIH funding. All right, I want to not going to go in a whole lot of detail about these disorders because I don't have time, and most of you are familiar with these. The ones on the top are called the tauopathies. Those include progressive supranuclear palsy and the variants thereof, mainly centered around abnormality of a protein called tau, and specifically 4-repeat tau, as well as cortical basal degeneration, also a tau disorder, 4-repeat. Alzheimer's disease also has some tau pathology. But it's a little bit variant on the type of tau that's involved. That's a 3-repeat, 4-repeat tau combination. And all those are disorders that primarily affect neurons first and then can also affect glial cells secondarily. The ones below are 2 examples of what are called synucleinopathies. The disordered protein in these disorders, multiple systems atrophy and Parkinson's disease, is alpha-synuclein. In the case of Parkinson's disease, this alpha-synuclein aggregates and is deposited primarily within neurons, whereas in multiple systems atrophy, the primary pathology starts in glial cells, not in neurons, but eventually the neurons do become affected. So I'm going to divide my talk into talking about drugs directed at the tauopathies, that is cortical basal syndrome, progressive supranuclear palsy, and then move on to a synucleinopathy, which is multiple systems atrophy. The other thing I wanted to point out is a lot of the movement forward in these areas is due to the similarities in the key proteins involved. So there's a lot of people that have Alzheimer's disease, far fewer that have PSP and CBD, but a lot of the therapies for Alzheimer's disease are directed at tau, and they can also then be applied to the other tauopathies like PSP and CBD. Similarly, for MSA, a lot of drugs are being developed for Parkinson's disease, a far more common disease, but those alpha-synuclein targeting drugs can also be used in part to address the alpha-synuclein pathology that you see in multiple systems atrophy. So there are friends involved. So let's talk about PSP and CBD, and I'm going to talk about them together and talk about a tale of tau. Well, so what is tau? Tau is a microtubule protein. It's involved in a number of really important things for a nerve cell. That's nerve cells that connect and transmit information back and forth. They allow the nerve cells to move cargo up and down their axons, which are the long connecting wires that connect the nerve cells together. They also allow those endings that are the connections between the nerve cells to be modifiable or adaptable, and also help regulate the genes and how the genes are expressed in those nerve cells. So microtubules have a particular protein in them called tau, and tau helps stabilize those microtubules and allows the nerve cell to function properly. Now, when tau becomes abnormal, that is when it becomes phosphorylated or acetylated, it starts to disrupt those microtubules. So what happens when tau breaks bad? This is one of my favorite TV shows of all time. I don't know if anybody's seen that. But the following things can happen when tau goes bad. And primarily, we think it's because tau becomes modified by adding other molecules to it, like a phosphate group. We call that phosphorylation. And the enzyme that does that they're called kinases. And then there's another modification called acetylation or acetyl group, which is added by an enzyme called acetyltransferase. So when tau becomes phosphorylated or acetylated, it stops functioning, the microtubules destabilize, and the neurons lose those essential functions of the microtubules. There's also a gain of function that occurs as well. So these fragments of tau that are then coming out of this disintegrating microtubule environment start to aggregate together and cause further mayhem. Now, there are machineries in the body, namely something called the lysosome and proteasome, that are designed to clear that garbage out, so those misfolded or mislabeled proteins. But those quickly become exceeded, and then that abnormal tau begins to aggregate in something called neurofibrillary tangles. And when a pathologist looks at a brain of somebody that has PSP or MSA, that's one of the things they're looking for, is for neurofibrillary tangles. We also know that this leads to a cascade of the terrible trio I have listed below: neuroinflammation, mitochondrial dysfunction, and oxidative stress that ultimately leads to activation of cell death pathways. The other thing that happens is the diagram listed below. This is the transcellular spread. So when one cell dies from abnormal tau, the tau is released into the extracellular space. Then it can get taken up by its neighbor neuron that's normal. That abnormal tau then binds to the normal tau and causes that to assume an abnormal configuration. The microtubules start destabilizing, and the cycle repeats itself. So that's kind of the cascade of events that is thought to occur in these tau disorders, CBD and PSP. So that gives us a rich field of definite targets we can go to that are relevant to the disease. So we can try to restore the function of tau by stabilizing the microtubules. Well, we've tried that with two drugs, divanitide and abiraterone. These, unfortunately, were not effective or caused intolerable adverse effects like worsening cognitive function, increasing falls. So those were abandoned. We can prevent the abnormal modification of tau. So if we block those enzymes that stick on those phosphate or acetyl groups, maybe we can reverse some of the pathology. So there are a number of what are called kinase inhibitors that add those phosphate groups. Some of them are called GSK3B kinase inhibitors. There's some ones that are already on the market for other things like lithium, valproic acid, and the other one that's listed there. They've been tried, but they were either of no benefit or not well tolerated. A third one listed, thiadiazinylin, they make those really hard to say. Thiadiazolindone, there you go, was tried in an early phase 1/2 trial. It did demonstrate some less brain atrophy in the patients that took this medication, but unfortunately there was no evidence of clinical improvement. Another kinase that's attracted a lot more attention both for Alzheimer's disease and for CBD PSP is CDK5. There is a CDK5 inhibitor that's already in phase 1 clinical testing and many more that are on the way. The one that's in testing right now is tolfenamic acid. And then there's another one called sodium selenate, which is in phase 2 trials in Australia. The other modification to tau that causes it to break bad is adding an acetyl group, and there's a drug called salicylate. It's a drug that's already available for use in treating arthritis. Unfortunately, salicylate does bind to that acetylation enzyme, but it doesn't get into the brain very well. So salicylate itself is well tolerated by people with PSP and CBD, but very little of that drug gets in the brain. So what they need to develop is a brain-penetrant form of salicylate that does the same thing, and there are companies that are working on exactly that. And the final one is pretty exciting. It is a drug that adds a glicnac. I like saying that word, glicnac. So the glicnac gets stuck onto tau, and what that does is prevents the phosphorylation of tau. So the more glicnac you have on your tau, the less phosphorylation. So if you block the enzyme that removes that glicnac group, you can have more glicnac on your tau. Isn't that fun to say? So there's a drug called FNP223. It's undergoing a phase 2 trial that is currently recruiting patients with PSP to show that it's safe and effective and engages this target. So that's some exciting news going forward to drugs that modify the post-translational modification of tau. So how about we just get rid of tau, the tau that's released into the extracellular space that gets out and affects the next neuron and causes that one to go bad, and then that one dies and it causes the next one to go bad. If we bind up that tau, maybe we can keep it from doing that. So that's this idea of immunotherapy. Can we get antibodies into the system that will bind up that extracellular tau and prevent it from causing further mayhem? So there are a number of antibodies that you can infuse into the body. This is called passive immunotherapy, using antibody or antibody fragments. There's 3 that have been tested or are undergoing testing so far. None of these have shown efficacy. The one that's the most active one right now is the one at the bottom of that, UCB 107. It targets the mid-region of tau. It's completed phase 1 and started into phase 2. It is safe and tolerated, so we'll see about that one going forward. Even more exciting is immunization versus tau. So if you give a vaccine that causes your body to make its own antibodies. So it's hard to get antibodies infused into your bloodstream into the brain, but if you give a vaccine, the resident immune cells that are already within the brain can produce some of those antibodies. So they have a vaccine called AAD-VAC1. It's completed phase 2 testing in Alzheimer's disease. It's now going to be tested in PSP in the platform trial that was previously mentioned. So very exciting that we may have a vaccine that reduces the burden of extracellular tau in the brain and can slow the progression of that tau from one cell to the next. There are a lot of other tau antibodies and tau-related vaccines that are being developed for Alzheimer's disease that haven't yet transferred over to PSP or CBD, but they certainly should be able to do that. So like I said, you have allies in this fight against tau. So what about just shutting down the expression of tau? Maybe we have too much tau around. We're trying to clear it out by opening up the drain and draining it out. Can we just shut off the faucet and not make as much tau? Well, you can bind up the signal that allows the cell to generate tau. One of those approaches is called using an antisense oligonucleotide. It binds to the part of the DNA that tells the cell to make tau. There's 3 that are listed that have been tried. The one that's in the most recent stage of development is the last one, the NIO725 compound. It's currently in completed phase 1, going on to phase 2A testing when they're first starting it in people that have progressive supranuclear palsy. You can decrease tau aggregation. So you can't get rid of tau, you can't stop it from being made, but can you stop it from glomming onto each other? These are aggregation inhibitors. There are 2 that have been tried. One is this ANLE compound, and we'll come back to that because it also prevents the aggregation of alpha-synuclein. And there's another one called LMTM that's in phase 2 trial testing. And Alzheimer's disease appears to be safe and tolerated in that population, easily transferable over to CBD and PSP. Now, could you all do something else to clear out tau? Well, you can direct tau to the machinery that gets rid of that clumped up or abnormally labeled tau. One drug that does that is AZP2006. I'm not going to try to pronounce that name. It improves the function of a lysosome. That's one of our 2 garbage disposals for misfolded or aggregated proteins. It's regulated by a molecule called progranulin. AZP increases progranulin signals and activates lysosomes to remove abnormally folded or labeled tau. This is completed phase 2A testing with encouraging results, and this is the second drug that's included in the PSP platform trial that was mentioned earlier. The other ones that got me really excited but are in that preclinical phase of testing or maybe early phase 1 testing are things called PROTACs. Those are proteasome targeting chimera. These are molecules that go into the brain and bind to the abnormally labeled or aggregated tau and direct it to the second garbage disposal that it doesn't normally go to, called the proteasome. So it shunts it to this other spare garbage disposal to get rid of the misfolded or mislabeled protein. These are called PROTACs. And there's a large number of PROTACs that are being developed not only for tau disorders, but also for alpha-synuclein. So I think that's another field where I have a lot of excitement for the future. Now there's a little handful of drugs that don't fit into a need category that I'll go over that are important to note. There's one called AMX0035. This is the Orion study. It's currently ongoing. It's a combination of 2 drugs that target mitochondrial function and protein homeostasis. These drugs were previously trialed in another neurodegenerative neuromuscular disorder called amyotrophic lateral sclerosis, or ALS. It was well tolerated in that population, but didn't produce the results they were looking for. But now they are testing it in phase 2 trial for patients with progressive supranuclear palsy. There are 2 interesting antiviral drugs that work on an enzyme called reverse transcriptase. The first one is GV1001. This is a drug that's being developed in Korea. It results in anti-inflammatory and antioxidant properties that should slow down the progression of these neurodegenerative disorders. They have completed a phase 2 trial in Korea that show that it is indeed safe and effective. They're deciding if they're going to move forward with that. Another one is the TPN-101 nucleoside reverse transcriptase inhibitor. The idea here is this drug appears to stabilize something called chromatin. Chromatin holds your DNA together and keeps it from disintegrating when your cell decides it's going to die. And this kind of prevents that from happening. This is also in phase 2 testing here in the United States. The last two are an antioxidant called NBMI. Again, I'm not going to attempt to pronounce that since I failed so miserably on the earlier ones. This has antioxidant metal-chelating properties. It's been tested in phase 2 in people with PSP and MSA. It appears to be safe and well-tolerated and will likely move forward. And then there's a small study out of Norway using a dietary supplement called nicotinamide. It's a vitamin. It has some reason to believe this will be helpful in reducing some of the energy imbalance that's seen in both PSP and CBD. I will just touch briefly on development of new symptomatic therapies. Donepezil is a cholinesterase inhibitor, was developed to treat Alzheimer's disease dementia. They're testing this in progressive supranuclear palsy to see if it helps improve memory function and reduce distractibility. They tried this with another cholinesterase inhibitor called rivastigmine. That did seem to help a little bit for cognitive function, but also appeared to worsen motor function, so will likely not be pursued. Sleep fragmentation is a common problem. I'm sure you're all familiar with that. And trying to find ways to improve sleep efficiency is an avenue that may produce some improved quality of life. And there's a phase 4 study looking at 2 FDA-approved drugs to help improve sleep efficiency. A subcutaneous dopamine agonist is also being studied to reduce pain and improve quality of life. And then finally, we just finished enrollment for something called the TOPAZ study. I don't know if anybody got into the TOPAZ study. So people with Parkinsonisms, whether it's MSA, PSP, CBD, Parkinson's disease, have a tendency to fall. When people fall, they tend to break their hips. They break their hips at a higher rate than people that don't have these disorders. We know that this drug, zolendronate, reduces hip fracture rates in women who have osteoporosis. So we wondered whether this drug would reduce hip fracture rates in people with Parkinsonism, including PSP, CBD, and MSA. So this study was a large study, almost 3,000 patients, was just concluded. Now we're going to follow these people over the next 3 years to see if we have an impact on hip fractures in these populations. All right. I've just touched on the ones that made it so far that haven't got killed off. There's tons of drugs that have been tried that failed. Why have so many previous trials failed? Well, these are some of the challenges. We're likely diagnosing these conditions too late. The horse is already out of the barn, and shutting the barn door at that point sometimes may not make a difference. So we need to find ways to diagnose these conditions at an earlier stage. That butts up against the next problem, which is misdiagnosis. So people diagnosed with these conditions that don't actually have that condition. So one of the challenges is you push the diagnosis using just clinical signs earlier, you increase the amount of patients that are misdiagnosed. So we really need a biomarker that helps us make these diagnoses earlier. There's also a wide heterogeneity of presentations with distinct natural history. So within progressive supranuclear palsy, there's a PSP Richardson syndrome, which is the kind of classic progressive supranuclear palsy, but there's a PSP Parkinsonism, there's a PSP gait disorder, there's a PSP speech disorder, and all of those have different rates of progression. And then a lot of this centers around poor biomarker support. We really need better biomarkers. So what's new? I think we're making a lot of progress, and this is a question that was asked earlier about biomarkers. We're making a lot of progress on imaging and fluid biomarkers, so imaging ligands that detect tau in the brain, using something called neurofilament light chain, which is elevated in people with PSP and CBD, and does track with the progression of the disease. So as the disease progresses, the amount of neurofilament goes up, and so that makes a nice way to track to see whether you're making a dent in the rate of progression. Thinking about studies that have broader inclusion, that include both PSP and CBD together, because we need to treat these populations together. Many of the therapies are directed at the same thing. And I think Christos mentioned earlier these things called basket studies, where we include multiple different types of populations. And I think that's a novel and innovative way of approaching that. Earlier intervention will be helpful. And then, as was mentioned earlier, finding a way to accelerate discovery. Accelerate discovery is taking too long. How do we get these drugs through phase 3 to find the best targets, the fastest horses to ride on? So if we can test 1 or 2 or 3 drugs at the same time versus one control or placebo group, that would really rapidly increase the pace of discovery. And in fact, that's exactly what this PSP platform trial is designed to do. All right, I'm going to shift gears and talk just a bit. I don't have a whole lot of time left, but I will do my best. So this is multiple systems atrophy and some description of its pathology. As I alluded to earlier, this is based on a protein called alpha-synuclein, but the disease tends to start off in something called the glial cells, and particularly the oligodendroglial cells, which is shown on top. When there's too much or aggregated synuclein in these oligodendroglial cells, there's a protein called P25 alpha that changes its position within the cell, causes the cell to start swelling up and dysfunction, and then the alpha-synuclein within those cells becomes modified like the tau does and aggregates and clumps together and can form inclusions. What does the oligodendroglial cell does? Well, the oligodendroglial cells forms the insulation of those wires that connect your nerve cells together. And that helps promote the health and survival of your nerve cells, allows them to communicate with each other. So when those oligodendroglial cells start dying off, the nerves don't talk well to each other. In addition, when those oligodendroglial cells die and release their alpha-synuclein that's clumped up or modified, it can get into normal nerve cells, get into that normal nerve cell and find the normal synuclein in those cells and cause that synuclein to go bad, then cause the nerve cell to go bad. So there's a cascade of events that, again, are centered around this protein called alpha-synuclein, its aggregation and modification. But like with the tauopathies, this gives us a rich field to target. We can shut off the production of alpha-synuclein by binding up the signals to the DNA that allow it to be produced. We can inhibit it from misfolding or aggregating or clumping up. We can give antibodies to suck up all that extracellular synuclein. We can prevent aggregation of synuclein. Or we can improve the degradation of a synuclein. So pretty much the similar approaches we were using with tau are applicable to synuclein. It's just a different protein. So you can use vaccines against alpha-synuclein. There are a couple that are in development originally for Parkinson's disease, easily transferable over to MSA. There are passive immune approaches using monoclonal antibodies. A couple are listed there. And then there are antisense oligonucleotides that shut off the signal to make alpha-synuclein. All these things are available now to be transferred over to therapies that could be developed for MSA. So these are ones that are in early phase 1 testing for multiple systems atrophy. So at the top are 2 immunotherapies and 1 antisense oligonucleotide. The immunotherapies are generating antibodies that bind up the synuclein. The antisense oligonucleotide shuts off the cell from producing extra alpha-synuclein. The ones listed below are ones that improve the degradation of abnormally folded synuclein or prevent it from aggregating together. And these are the ones that are in active phase 1 or early phase 2 testing for multiple systems atrophy. So just in summary, I'll review a couple of those. The one that is currently ongoing, recruiting right up the road in Farmington Hills and at other sites, is gene therapy using a growth factor called GDNF attached to a virus that allows your brain cells to produce GDNF. GDNF helps promote the survival of cells that seem to be programmed to die but are not dead yet, and also causes the ones that are still there to start sprouting and recovering. So this is more of a restorative therapy, which has got me quite excited, because all these other ones may halt where we're at, but it doesn't tend to restore function. This one may achieve that end. There are drugs that are aimed at reducing the inflammation and oxidative stress that occur from abnormal synuclein being released. There are aggregation inhibitors of alpha-synuclein. One is called ANLE 138B. The other one that was supposed to be listed on here but did not make it on here is this drug from one of our sponsors, Ono Pharmaceuticals, that just finished their phase 2 clinical testing of a drug that is a alpha-synuclein aggregation inhibitor type of drug. People are very interested in GLP-1 drugs. Anybody heard about GLP-1 drugs? Everybody's heard about those. So these stimulate insulin growth factor 1. This is deficient in the brains of patients that have a lot of different neurodegenerative diseases. There were some encouraging signals in early clinical trials with the GLP-1 targeted drug called exenatide in Parkinson's disease. So drug companies are pursuing this target, GLP-1, for diseases like multiple systems atrophy. Then there's another anti-inflammatory novel approach. There's a particular type of inflammation that's mediated by a complex of proteins called the inflammasome that tends to be unique for these neurodegenerative diseases. And there's a drug that specifically targets that that's under phase 2 testing for MSA. And then finally, I'll just briefly mention there's one stem cell trial that's being done by a company out of Japan, I think, and it's one of these basket trials that includes PSP, CBD, MSA all together, taking bone marrow cells harvested out of your bone marrow and turning them into neural progenitor cells and then putting them into the brain. That trial is just starting. That's an early phase 1A or early phase 2 trial because it's in the patient population to see whether this approach is safe and effective. All right. Looking ahead, I have hope. I'm an optimist, internal optimist. Progress is happening on multiple different fronts. There's a lot of drugs and a lot of targets to go after that are in the clinical trial pipeline, several of them in that kind of early clinical phase, but we'll soon get into the phase 3 trial where they may soon be available. I think we're making progress in diagnostic tools and biomarkers that will allow us to diagnose these conditions earlier and to track their progression and to refine our way that we're looking at clinical trials so that our populations are heterogeneous in a way that we understand rather than being heterogeneous in a way that we don't understand. Just to reinforce, you are not alone. A lot of people are interested in behind this. If you want to learn more about clinical trials, clinicaltrials.gov is a website that you paid for with your tax dollars. You can go in and enter in your disease of choice and filter by whether the trial is active, recruiting, if it's in your area versus in Norway or in Korea. You probably want to know that, right? And I always think about participating in research as a pay-it-forward system. All the therapies we have right now exist because people before us volunteered to do the trials to show whether they were helpful or not. So you can become involved. As mentioned earlier, there's a PSP genetic program that will help us understand the genetic heterogeneity of PSP and may help us identify genetic signatures of who might respond to drug A better versus drug B better. We can design clinical trials better if we understand that. And then there's another website from psp.org if you want to learn more about clinical trials. So while we're not quite there yet, I think we have real hope for moving forward for all three of these disorders. Lastly, I don't think I would be doing my duty if I didn't mention a thing that's really been troubling me recently. And that's funding for the National Institute of Health. This funds crucial health research for the disorders like we're talking about. It is the world's envy and driver of innovation and research in biomedical research. It requires less than 1% of the federal budget, but it has a huge impact. If you looked at the return on investment economically, 250% return on investment. Enables the training of future investigators, the next generation that are going to be working on these really, really important problems. As I mentioned earlier, 98% of the FDA-approved drugs were only achieved as an FDA-approved drug because they had NIH funding. Now, I think we're all in agreement the government could be more efficient, and I'm all in favor of the government being more efficient. But the 40% proposed cut to the NIH budget is not an effort of efficiency, it's a wrecking ball. And it's a devastating outcome if that comes to pass that will be really hard to recover from. So I will get off my soapbox at that point, and hopefully we can have a discussion going forward. We'll invite Dr. Sid back up here and take your questions.
Okay, I believe we have time for 2 quick questions if folks have one. And please make sure to put the microphone up to your mouth as you ask a question.
Far be it from me to understand what was going on there. But one question I do have is that some time ago there was an article that came out that said that the vascular sorting protein VPS35 was able to untangle tau tangles in Alzheimer's disease. and it was looking like they were going to try to relate that to PSP. Do you have any comment on that?
Sure. It was, which protein again?
35.
VPS 35, yeah. So that's a really interesting target. A lot of that stuff. So I sit on an NH review panel that looks at these drugs that are at the late preclinical, earlier clinical phase. So just as they're making that transition from the lab to being something that can be tried in people, there are a lot of drugs that are targeting that. I can't really talk about that because it's proprietary information. It's a hard target to get to because it's inside the cell. So not only do you have to get it across the blood-brain barrier, you have to be able to get it inside the cell in order to target it. But there are a lot of companies that are indeed looking at that. So more to come on VPS 35.
My question's really, really quick. Are we going to get copies of your slides?
Sure.
Great. You talk faster than I can write.
Oh, I should have probably mentioned that ahead of time.
We'll get copies of everyone's slides. So no
I get
pressure.
excited and I talk fast. And you know, I could have talked about research for about an hour, but they only gave me about 15 or so minutes. So
Sorry about that. All right, that is all the time we have for questions right now, unfortunately. If you have questions, I'm sure you'll hang
yeah,
out for a
I'll
little
hang
bit.
out if you want to come and ask me individually.
Perfect.
Sure,
thank
Dr.
you.
Sid will as well.
All right, thank you both. That was phenomenal and really encouraging to hear and have explained to us.